Good morning to all. So we are going to discuss how to take psychiatric history. So we are covering the session in introduction, learning objectives, aim of the history taking, setting of the interview, duration of the interview, general principles of interviewing, elements of history taking and recording, techniques of history taking, and closing the interview. How to close the interview. So begin with introduction. So history taking in psychiatry is as similar as history taking in medicine, and it is somewhat different because psychopathology or pathology in the psychiatric examination is somewhat different, and it is similarly more or less like the history and examination done in the other subjects. So basically there are four types of professionals. One is biological and phenomenological oriented professionals who aim to discern the symptomatology, the psychopathology like delusions and hallucinations. Other one is cognitive behavioral approach, focus on identifying cognitive distortions and underlying assumptions or inference of the cognitive distortions. The professional with psychodynamically orientation uh, focus more on the indication of unconscious conflicts in the mind. Behaviorists investigate hidden patterns of anxiety and association between the stimuli. So therapeutic listening necessitates an acute awareness of the narrator's perspective along the capacity to harmonize the patient-centered approach with a focus on the disease. The learning objective of this session will be identifying the significance of history taking, the fundamental principles governing history taking, and diverse components of the history taking process, and various techniques and models of interviewing the patient. The preliminaries are, first one is the components of the psychiatric interview, like how to begin the interview, how to open the interview, the interview itself as a whole, and how to close the interview. So one skill which is required in psychiatric assessment is active listening, because most of the psychopathology is reflected in the speech of the person, which is reflection of the thinking in the mind of the patient, and doctor should monitor the content of interaction, what patient or doctor say to each other, the process of interaction, what the patient doctor may not say but clearly convey in many other ways like non-verbal communication. So assessor should be sensitive to the effects of patient background, the culture of the patient, the environment of the patient, and psychology of the patient. The more that doctors understand themselves, the more secure they feel and the better able they are to modify destructive attitudes. Increased flexibilities in communication or assessing leads to responsiveness to a subtle interplay between doctor and patient, and it increases the tolerance in the incidence of uncertainty which may come across through the assessment of the patient. So what are the aim of history taking? Aim of history taking primarily is the making a diagnosis which is based on the criteria, and this follows the identifying and labeling the patient's problem, predicting the course of the illness, how the illness will progress in the meantime, and the prognosis or outcome of the illness, whether it will be bad or good, ensuing the treatment decision on the basis of assessment and on the basis of diagnosis. So actually a psychiatric interview is about assessing the biopsychosocial aspects of the patient, which means the biological aspects, the psyche of the patient, and about the social environment in which the patient is living. So in first interview, you can say that first impression is the last impression. So first session of the interview should be like that. uh, it will uh, it will make a good image or get good image of patient physician relationship, and which can greatly affect the effectiveness of the treatment outcomes. Now we will talk about the setting of the assessment. The setting can be a psychiatric inpatient unit, medical or surgical inpatient unit when you will get the referral from medicine or surgical side. Emergency rooms, outpatient departments, etc. can be the setting. So for an ideal interview room, this should be a somewhat relatively soundproof room, and furnishings and the decor should be pleasant and not distracting to the patient, so a smooth interview and assessment can be followed. Interviewer's chair and patient's chair be of relatively equal height, so one can communicate effectively with each other. The two should be seated approximately 4 to 6 feet apart, and there should not be any desk between the assessor and the assessee. So the desk between two can act as a psychological barrier, so desk should be not there or should be removed. The therapist should dress professionally and be well groomed. Distractions should be kept minimum, like no telephone or beeper interruptions should be there. And if any call comes in between the interview or assessment, one can ask the patient to take the call. So the thing should be set as such that the time has been set aside just for the patient, and it is the only his privilege to get your time. Now, duration of the assessment. An interview is an ongoing process, it is not cross-sectional process. The assessment may go on to the further 2 to 3 sessions for initial making a diagnosis or establishing a management plan. So the typically initial interview lasts between 45 to 90 minutes, and in case of medically compromised patients and acutely disturbed or hostile or violent patient, the duration can be reduced to 20 to 30 minutes or even less to implement the management plan early to curb the problem. Clinicians must acknowledge that the history gathering during these interviews is seldom complete or entirely accurate. So it's an ongoing process. The remaining information can be gathered in further sessions, and even the diagnosis has been made. The further follow-ups is also require a mini school assessment or assessment of the progress of the illness and outcome of the illness, and how the things are going. So now coming to the general principles of assessment. So first of all, you have to introduce yourself and greet the patient by name. Reassure privacy and confidentiality. Put the patient at ease, for example in L-shaped position, and there will be no intervening desk, not directly in front of each other. This means the one can both can sit in a 45-degree of angle, so there will be a space for silence, and the patient have to think of some situation, and they have to think on revealing the or going back into the memory to take the time. So direct eye to eye contact shouldn't be there. There should be a space for silence also. Suitable distance, as we have discussed earlier, will be uh, maintained. And in case of geriatric patient, this can be the distance can be less also, because the geriatric patient are somewhat they have sensory deprivation. They may be using hearing aid or visual aid, so one can have a less distance. And in case of aggressive patient, the distance can be increased, for example up to the 15 to 20 feet of uh, distance. Be supportive to the patient, be attentive to the patient, and be non-judgmental and encouraging. Judgment may be verbal or non-verbal. Explain the purpose of the interview and expected time is what the expected time is needed for the assessment. Observe the patient's non-verbal behavior and avoid excessive note-taking. For example, in case of persecutory delusion, the patient may become apprehensive in such circumstances because of their delusional belief. They may think that the excessive note-taking is against them, and they may become guarded or may not come up with their problems openly. So next point is with whom you will start the interview, like the patient or the relative, and if both are the informant or any of one is informant, the source of information should be mentioned in the summary. And rate the adequacy of the obtained information. If the obtained information is adequate enough to make a diagnosis or management plan, and if needed, opine on the need of more details in further sessions. Determine the reliability of the informant. How reliable are the informant? We will discuss later in next slides. One question is, why did they come with a relative? And this may indicative of some sort of illnesses which may be psychotic. In case of psychosis, insight is absent, so most of the patients come with their relative. And in case of neurosis also, they may come as a social support. Start with the open-ended question, then be more specific. Open-ended questions are like if you ask a patient regarding the breakfast he had in the morning, this will give a very less sorts of words, and patient be reply in a one or two or words or sentence. And if you ask the routine of the patient, daily routine of the patient of the day, then this will be more fruitful, and then this will give more comprehensive answer. So you can make out if the patient is having coherency or irrelevancy in the speech or not. Closed-ended questions are required when time is lacking or a specific piece of information needs to be obtained. Consent for the interview. Do take the consent for the interview, and it is an essential part. Privacy and confidentiality is also important. It should be indicated at the beginning that the things will be private and confidential, except for the situation where it is needed, like in forensic examination and disability evaluations. These are less confidential. If a person intends to harm another person or themselves, this is also have to report to the appropriate authorities and to warn the potential victim. So these type of information and evaluation are less confidential. If you are interviewing the patient alone and he had come with family members, then the things can be discussed with both the patients and family member after the patient's consent has been obtained. Fully informed about the recording. If you are doing a video recording or audio recording, they should be fully informed and how the recording will be used in the future. Patients should be informed of the use of one-way mirror. In some scenario, one-way mirror room is used to teach the trainees how to proceed with the assessment and interview. In such a situation, one should inform that we are going to use the one-way mirror room, and you will be observed by the trainees. In general principles of assessment, respect and consideration is also a very important aspect. Do respect the patient, and they should be treated with respect, and one should be considerate of the circumstances. The patient may come with various circumstances like non-compliance and long-standing psychiatric illness. So considerate, one may feel offended, so be considerate for the circumstances, and do not get bothered or offended with the situation. And try to reduce the stigma. You very well know that psychiatric illness have a stigma in the society. One should attempt to decrease the distress because of the stigma. Rapport and empathy is also important. Rapport can be defined as harmonious responsiveness of the physician to the patient and the patient to the physician. So this is a bi-directional communication which is harmonious between the two. If you are asking the question and patient cooperating and responding appropriately in interview and in examination also, so a good rapport reveals the good outcome, and it is the making of the diagnosis will be easier. So a whole psychiatric interview should be patient centered, which means the patient's early life experiences, his family, his education, occupations, his religious beliefs and practices, and hobbies, relationships with each other, and even the losses should be taken in consideration. Genetic and biological variables are also important. So patient should be seen as a whole, not as a the patient is having psychiatric problem or he is having only psychopathology. So to develop rapport, one can exercise 6 strategy to develop a good rapport. Like first one is putting patient at ease and pacify the patient for what we are here to help and we are here to solve the problem. Finding patient's pain and expressing compassion is also helps in developing good rapport. Evaluating patient's insight and become an ally. Showing expertise to an extent is also good in developing rapport. Establishing authority as a physician or a therapist. Balancing the roles of empathetic listener, expert and authority. So do not become a total empathetic listener or totally expert or totally an authority. Balance the role of all these aspects of your assessment. Do take care of the safety and comfort. Both the patient and the interviewer must feel physically safe, and in case of hostile and violent patient, the assessor should take care of himself or herself also, and for the safety of the patient also and the environment. While doing assessment of psychiatric patient, have a clear obstacle-free exit path. In such a situation of hostility, one can flee and ask for the help. Psychotic or confused patient may feel threatened and needed to be reassured that we are not the threatening person. We are here to help them. In case the things goes beyond the boundaries, one can terminate the interview if the patient becomes more agitated and threatening. So two terminologies also used during the assessment, which is known as transference and counter transference. The transference is the feeling which the patient have towards the physician, which for which he is having for the another person in his life. For example, if the person is having a good image of father, then that image can be thoughted upon the physician. Or this transference can be negative or positive, both. One can have a good image of the assessor, one can have a negative image of the assessor in case of uh, delusional delusional thinking. One can see the assessor as a threatened person. Counter transference is something which the emotional reaction to the patient from the doctor side. So doctors can also have a transference like feeling, which is called as counter transference, and most of the time these counter transference are negative in case of the doctor's view. So when you feel like developing counter transference with the patient, and it goes beyond and cannot be tackled upon, so one can shift the patient to the another therapist or another assessor to look upon the situation. So there are four models of doctor-patient relationship. One is the mutual participation model, which is known as the best model, and it is most appropriate model for chronic diseases. In this model, treating physician and patient are responsible for therapeutic process. Though, so they both of them are agreed upon the therapeutic process and the management plan. The active passive model is treating physician is responsible of the therapeutic process regardless of the patient cooperation, and this is most appropriate method for the emergency situation. The guidance cooperation model is like teacher student relationship, parent child model. In this model, treating physician is responsible of the therapeutic process and the patient cooperates totally with the therapist. So decision may not be satisfactory to both the parties in this model. This is the most commonly used method in medical practice, in which the patients are totally dependent on the therapist for all the doings, like uh, the choosing the drug and all. The fourth one is friendship model. It is also called a socially intimate model, and in this model may arouse the boundary issues between the therapist uh, and the patient. Now talking about the interview skills and techniques. Some techniques are used in interviewing, which are which facilitates the interview, and the things goes in a good manner. So one is reflection, and in reflection, a doctor repeats to a patient in a supportive manner something that the patient has said. So the doctor repeats the word of the patient, what the complaints he is coming with. So this is the reflection. Facilitation, doctor helps patient continue the interview by providing both verbal and non-verbal cues. So this is facilitation. So interviews is facilitated by the verbal and non-verbal cues like head nodding and uh, giving agreement voice. Silence and empathy. Silence is also important. We have already discussed the sympathy and empathy. Sympathy is emotional acknowledgement of the other people's distress, and empathy is emotional acknowledgement plus understanding the reasoning behind the distress. So what the basic difference is? Sympathy is somewhat the situation in which for example, a patient has lost financially, but uh, the therapist can have sympathy because he has lost, but he has not experienced that loss. The therapist has not experienced that loss. In empathy, empathy is the emotional acknowledgement when the therapist had also experienced such a situation for which the patient requires empathy, like loss of father. So if the therapist lost his father and the patient is talking about losing his father in the assessment, so if the assessor has the sympathy, this is called as empathy actually. Confrontation mean to point out patient something that the doctor thinks the patient is not paying attention to, is missing, or is in some way denying. So if the patient is not attentive towards some sort of information, so one can confront to gather that information, or if any information is missing or the patient is denying about some uh, problem in the life, like drinking pattern of alcohol, the amount of alcohol, usually they deny that much of amount of alcohol consumption. So one can confront to gather the real situation. Clarification is attempt to get details from the patient about what they have already said, and attempt should be made to clarify the vagueness of the chief complaint. So clarification can be sought if the things are not clear, or vagueness of the chief complaints. Interpretation is most often used when doctor states something about a patient's behavior or thinking that a patient may not be aware of. So interpretation can be made out of the conversation, so for which the patient is not aware of. One therapist can or assessor can interpret the situation by circumstantial evidences or otherwise. Summation is periodic summarization of what a patient has said thus far. So in total interview, in the intervening period, one can summarize or summate the discussion they had till that time. So this is called as summation. Explanation is explanation of treatment plans to the patient in easy understandable language and allow patients to respond and ask questions. So explanation should be provided if question has been asked from the patient side. Transition is transition from one topic to another, is also a part of interview skill, and it describes a transition across different areas of history structure, and the transition should be smooth and non-interrupted. For example, you are going from history of present illness to past illness, so transition of conversation from history of present illness to past illness should be smooth and non-interruptive. Self-revelation. Limited, discreet self-disclosure by physician may be useful in certain situations, and physicians should feel at ease and should communicate a sense of self-comfort. Though the placement of boundaries is still pivotal, so a limited information of self should be revealed and can be, or if some aspect is being correlated with their self life, should be in a limited fashion. Reassurance and advice is also important. Reassure the patient about the beneficial effect of the management and treatment, and advice obviously be given. There are some obstructive techniques, those techniques which can hinder your assessment, and the things may not clearly expressed by the patient. So what are those obstructive techniques of interview skills are? The excessive use of closed-ended question. So do not use closed-ended question, as we have already discussed that closed-ended question will lead to a smaller form of answer and will not give a big and a vast picture of the situation. For example, do you have friends? This will give only one answer. Compound questions. Do not mix more questions in one go. Like how did you feel, what did you do, or what your father does. So do not ask in a one go. Excessive why questions are also not important and can create obstructions in the assessment, and more information cannot be gathered. So why question should be avoided. Judgmental question, that like do you know that yelling only make matters worse. So don't make judgmental questions which may hinder the assessment progression. Minimize patient concern. Minimizing patient concern. So patient having panic attack may think that this attack is related to myocardial infarction, or he might be having a heart attack, and he is very concerned with that panicky situation. And as a therapist and as a expertise, we know that the panic attack is not a situation, lethal situation. So, but patient concerns is not cannot be minimized. Patient have the concern, you have to give the importance to the symptomatology. Premature advice is also a hindrance in assessment. Do not give premature advice before knowing the situation in detail. Premature interpretations are also like that, making interpretation before knowing all the aspects of that pathology or that situation. Do not interpret in between the assessment. Abrupt transition is also not advisable. Ambiguous non-verbal communication, like looking at your watch, turning away from the patient, yawning, refreshing the computer, and other things should be uh, removed from the assessment part. Elements of history taking and recording. Now we will discuss the structure of history taking, the subheadings under which the history is to be recorded and to be taken. So first is the identifying data. Identifying data includes the patient name, age, gender, his education, occupation, and marital status, race or ethnicity, socioeconomic status, and area of residence. Source of referral should also be coded. Like a source of referral also indicate many things, like if the patient came alone, the probability of neurotic illness is more. If the patient is coming with the relatives and too many relatives, may indicate the violent situation, or the patient is having psychotic illness. And if the police personnel or authorities are coming with the patient, this may show that the patient might maybe coming for forensic assessment or disability assessment. So source of referral is also important part of the assessment. The source and the reliability. Source of information should be recorded if the source of information is more than one person, then all the source to be recorded, like patient, relatives, authorities, notes of the patient, diary of the patient should also be coded. And reliability of those sources should be indicated in the case sheets, like coherency of the person who is depicting the history, how consistent he is in uh, his statements, whether he is caring or not to the patient. Adequacy of information should also be noted, and whether the person is living with the patient or not is also important. Now coming to the chief complaints. This should be patient's complaint, and ideally in their own words, in their own verbatim. For example, I am sad, neighbors are trying to harm me. The question should be asked like, what brought you in to see me today? This is a open-ended question, and this will give more information, more uninterpreted information. And another example is, tell me about the issues you have been experiencing. This will also to elicit the chief complaints. In our setup, the common chief complaints in OPD settings are like मन उदास रहता है, नींद नहीं आती है, घबराहट बेचैनी रहती है, नशा संबंधी शिकायतें हो सकती हैं. इन केस ऑफ मैनियक पेशेंट द चीफ कंप्लेंट्स बी लाइक ज़्यादा बोलता है, बड़ी बड़ी बातें करना, गुस्सा करता है, ज़्यादा एक्टिव रहता है. इन केस ऑफ ऑब्सेसिव कंपल्सिव डिसऑर्डर इट मे बी लाइक बार बार हाथ धोना, लॉक चेक करना. In case of psychotic illness like schizophrenia, the complaints may be of suspiciousness, शक करता है, नहाता धोता नहीं है, या अपने में ही रहता है, या बाहर बिना मकसद के घूमता रहता है, बड़बड़ाना, अपने आप से मुस्कुराना. So all these chief complaints are common chief complaints in OPD settings. In emergency setting, in a study, this has been found that suicidal ideation and attempt were in the case of 39% of psychiatric patient, psychotic symptoms in 14% patient, substance abuse in 12%, behavioral issues in 10% patients, depression in 10% patients, anxiety were the complaints in 9% patients, and medical problem in psychiatrically ill patients were in the 4%, and homicidal ideations in 0.4%. So while assessing the history, or while taking the history of present illness, one should consider few points in the mind which we will discuss in next two slides. Is the narrative should encompass the progression of symptoms observed in the current episode only. One should not consider the past illness or the incident which happens far away before the illness to be considered in current episode. There should be temporal correlation between the precipitating factor also, which should be the part of the current episode, and one should talk about the current episode for all the things in chronological manner, and one should record the nature, onset, severity, and the progression of the symptoms in the timeline history. Furthermore, any change in the interpersonal relationship between family members, behaviors of the others and the patient, if any change in the personal habits of the patient, if there is any change in the physical health of the patient due to the psychiatric illness, biological functions like sleep, appetite, sexual functions should also be recorded, and the degree of socio-occupational impairment due to the illness. Additionally, absence or presence of stressor should be recorded, which may encompass circumstances related to home, related to work, educational settings, legal challenges, medical comorbidities, and interpersonal conflicts. Equally significant are the factors that may mitigate or intensify the symptoms, such as pharmacological treatment. If the patient is on treatment from another psychiatrist for the last few months or few weeks, and he came now to you, and the symptoms may be diminished because of the pharmacological treatment, this should also be taken into account. Social support can also intensify or dilute the symptomatology, like good social support. In case of good social support, symptoms are not that much intensified, and may be intensified in case of poor social support. Coping mechanisms of the person is also important to to give weight to the symptoms intensity. Variations throughout the day in the symptoms also taken in the account. If you are doing the evening clinics, the morning worsening of symptom in case of depression would not be seen in the evening time. So this part is also important. One thing is, ascertain the reason behind the current consultation. The patient may be consulting because of some sort of reasons, like if he is not getting well, or he's having certain kind of side effects because of the previous treatment, or because of the poor financial condition. He may come to you, he cannot afford the private institution because of the financial reason. So reason may be more than one or maybe many, so should be recorded. Identify the precipitating and maintaining factor in the illness. Precipitating factor which precipitates the illness, like stressor, maybe a financial loss or loss of loved ones, and it may be a substance abuse also. In maintaining factors which maintains the symptoms and hinders the outcome of the treatment or management plan, which maintaining the illness, like interpersonal conflicts, like substance abuse, should also be noted. Any treatments administered in the current episode. If the person was in follow up some another therapist, so nature of intervention should also be recorded, and specific modalities employed should also be recorded, like whether the patient was treated by means of drugs, by means of psychotherapies, or by means of electroconvulsive therapy. So specific modalities should also be noted. Evaluate the adequacy of these treatments. These treatment should was given in adequate amount or adequate period of time, should be noted to label the patient as a treatment resistant or not. Incorporating a psychiatric review of system which have a and which enlists a series of symptoms of various psychiatric disorders that can be also screened upon the review system of psychiatry. Furthermore, documenting a negative history is also important. In negative history, what we do is, if the person is having certain sort of symptoms, like symptoms of psychosis, like delusions, hallucinations, and oddities in behavior, so these set of symptoms may be found in other psychiatric illnesses also, like pervasive developmental disorder or other non-organic psychotic disorder. So one has to take the history, negative history of related symptom which may be found in other illnesses first, and secondly, rule out all other psychiatric diagnoses, like obsessive compulsive disorder, depressive disorder. If the person is having manic features, so one can have the schizoaffective disorder instead of schizophrenia. So related disorder are also checked. The third one is neurological disorder. If the person is having any sort of um, seizure disorder or having any sort of head injury in the current episode, and like. Furthermore, document the history of medical illnesses in the current episode, like diabetes, thyroid dysfunctions, tuberculosis, preceding history of fever, and so on. So common psychopathology which one will find in the history of present illness may be suspiciousness, hearing of voices, visualization of things which are not there, withdrawn behavior, apathy in case of psychotic illness, low mood, easy fatigue, lethargy, anhedonia means lack of interest in all the pleasurable activities, poor concentration, suicidal tendencies in case of depressive episode, over talkativeness, expensive behavior, hyper religious activities, reckless behavior, repetitive behavior in case of obsessive compulsive disorder, anxiety and panic in case of anxiety related disorders, intellectual deficits, socially deviant behavior in case of personality disorders, hyperactivity in attention in case of attention deficit hyperactivity disorder, whether it is adult ADHD or childhood ADHD, qualitative behavioral impairments in case of pervasive developmental disorders should also be taken into account. So one can see that all these things can happen with a normal person also, like sad mood or some withdrawn behavior for some time, lack of interest for a shorter period of time, hyper religious activity for a shorter period of time. One can have anxiety to a actual situation. So these behavior can be found in a normal people also, because we are not devoid of emotions, we are not devoid of behaviors, we are not uh, devoid of anxiety. So establishing a behavior as a psychopathology needs some qualities and requirements which can be the thing should be in excessive amount. If someone is having anxiety, that should be excessive, that should be long lasting, that should be for the most of the time, for the last few weeks, and that should be uh, irrational to the situation, like anxiety because of no reason, depressed mood because of no reason. So these features defines the psychopathology. It should be distressing to the patient. It should impairing in occupational or other aspect of life like sexual performance. In case of delusion, the thinking should be false. One have to prove false. The thing is false. This is non-correctable. It is not in the context of socio-cultural background and not in the context of intellect of the patient. In case of hallucination, this should be without external stimulus, and the things are not in the influence of the substance. In case of substance intoxication, the picture may be of a psychiatric disorder or psychiatric illness. So one should explore symptoms by in mind these points, that these points should be fulfilled to say the behavior or thinking as a psychopathology. Now coming to the past psychiatric illness, all the psychiatric illness in the past should be recorded, and their treatment, whether the treatment was taken on OPD basis or whether the patient was hospitalized, and what was the situation which precipitated the need for hospitalization, support groups were present or not, other form of treatment such as vocational training, occupational therapies were implemented or not, psychotherapies were implemented or not. Medication and other modalities such as electroconvulsive therapy or alternative treatment should also be carefully reviewed. And one should explore what was tried, the molecule which was tried, whether it was SSRI, SNRI, first generation antipsychotics, second generation antipsychotics, how long was the treatment given, and what doses these were used in past psychiatric episode. Also note why these were stopped. If in case of non-compliance, why were the treatment was stopped, either by the patient himself or the family himself or by the therapist. The response to the medication should also be noted, and modality already said. Whether there were any side effects of the drug which need to be keep in mind for in the management of current episode, or it may be a cause of non-compliance. So other reason for non-compliance should also be noted. If the patient was suicidal and having suicidal or self-harming tendencies, so lethality history should also be taken into account of the past episode, like past suicidal ideations, intent of these thoughts, whether the patient was having any plan or not, attempt were done should be reviewed, including the nature of attempts, perceived lethality of the attempts, or other death preparations like buying ropes, buying poisons, or other collecting other things to uh, for by virtue of which the patient may harm himself. Violence and homicidal history should also include any violent action or intent. History of non-suicidal self-injurious behavior should also be recorded, like parasuicidal behavior. Now come to the past medical history. So past medical history is also important part of assessment, which is not the part of as we have discussed in the negative history, that negative medical history. So past medical history may be a potential cause of mental illness, like long-standing diabetes or more co-occur with the depression, and that medical history may pose as a comorbid or confounding factor. This may confound the symptomatology. So and the past medical history also may dictate potential treatment options or limitations. If the patient having the history of diabetes, so one should take care of metabolic syndrome, the drugs should be used which do not cause the metabolic syndrome, and like the past medical history may precipitate a psychiatric disorder like recently diagnosed HIV, may precipitate depression. Hyperthyroidism may present as anxiety disorder, and the metabolic syndrome as we have discussed. In the past medical history, major medical and surgical illnesses and conditions as well as treatments, both past and present, should be recorded. Reaction to these illness and coping skills used during the past episodes should also be noted. It is important to pay special attention to the neurological illnesses like seizures, head injury, and pain disorders. Non-psychotropic medications like over-the-counter medications, sleeping aids, sleeping pills, herbal medications, alternative medications should also be reviewed in past medical history. Now come to the family history. Many psychiatric illnesses are familiar and the genetic load should be taken into note. How much is the genetic loading? Psychiatric diagnosis, medications, hospitalization, substance use disorder, and lethality history, if they are in the family, should be covered. There appear to be a familiar response to medication. The family history is also important, that the familiar response of medication is seen. For example, if one drug is effective in the family person for the same illness, may be similarly effective in the your patient also. A family history of suicide is a significant risk factor for the suicidal behavior in the patient itself, so it's also be ruled out and asked in the family if someone is having history of self-harming behavior or committed suicide. Family traditions, belief, expectations may also play a significant role in development, expression, and course of the illness. So tradition, beliefs, and expectation is also an important part of assessment. Also, the family history is important in identifying potential support as well as stressful situation in the patient's life. If the person is having a good family support, then it's a good prognostic factor. If the someone is having interpersonal conflicts with the patient, and that should be addressed to find the better management. Parents' age, consanguinity, illness, and if the patient died, mention the age and cause of the death should be noted, and patient's age at that time of the death of the parent should also be identified. Psychiatric illnesses in other first and second degree relatives like siblings, grandparents, uncles, aunts, nephews, and nieces should also be taken into account for making the genetic load. Positive history of psychiatric illness, drug abuse, homicide, suicide, substance abuse is also important in the management of the patient and should be noted. Relationship, if any interpersonal conflict with the family member or cordial relationship between the family members should also be clear cut and defined. So after of history of present illness, past illness, medical history, and family history, now coming to the personal history. The personal history examines the various phases of the patient's life and starts with the early childhood, and then the history of middle childhood, then the later childhood and adulthood. Now we will discuss the various aspects of personal history in the detail. The early childhood. The early childhood history comprises of prenatal history and mother's pregnancy and delivery. So point to be noted are length of the pregnancy, spontaneity, and normality of the delivery. If any history of birth trauma, whether patient was planned or wanted, and the history of birth defects. Feeding habit, breastfed or bottle fed, if any sort of eating problems at this time. Early development like maternal deprivation in case, language development, motor development, signs of unmet needs, the sleeping pattern of the newborn uh, child, object constancy, if the patient has developed object constancy or not, strangers anxiety, separation anxiety, toilet training has been done or not, at what age it was started, attitude of the parents, feelings about it, symptoms of behavioral problem like thumb sucking, temper tantrums, tics, head bumping, rocking, night terrors, fears, bed wetting, bed soiling, nail biting, and masturbatory habits should also be noted. Personality and temperament as a child, whether child was shy, was restless, overactive, withdrawn, studious, outgoing, was timid, athletic, friendly patterns of the play of the patient at this age. Reactions to the siblings is also noted in the personal history of early childhood. In the middle childhood, early school history is important. Feeling about going to school, early adjustment to the school, sex identification, and this may lead to sexual identification like gender identity disorder, and conscience development, punishments at school, and attitude towards it, social relationship with the peer group, attitude towards the siblings and playmates. In later childhood, peer relation should be noted. The number of friends, closeness to the friend, he was leader or follower, social popularity of the patient at that time, participation in group or gang activities, idealized figure at that time, patterns of aggression, passivity, anxiety, or any kind of antisocial behavior. In school history, how far the school from the home of the patient, adjustment to the school, and the relationship with the teachers. Favorite studies or interests should be noted. Particular abilities or assets should also be noted. Extracurricular activities in which the patient was appearing or participating in the extracurricular activities. Sports, hobbies, relationship of problem and symptoms to any school period should also be considered. Cognitive and motor development, learning to read and other intellectual and motor skills, if the patient is having any difficulty, or the patient has extra classes are needed or extra time was needed to learning to read or other intellectual activities. Minimal cerebral dysfunctions, learning disabilities and their management was done at that time, and the effect of these management on the children development. Particular adolescence emotional or physical problem at that time like nightmares, phobias, masturbation, bedwetting, running away from the school, delinquency, smoking, drug and alcohol use, weight problems, feeling of inferiority are also important. Religious background like it was strict religious background, liberal or mixed type of religious background with possible conflicts. Relation of the background to the current religious practice should be compared. In the later childhood, psychosexual history should be noted like early curiosity, infantile masturbation, sexual play with the peer group, acquiring of the sexual knowledge, attitudes of parents towards sex, any kind of sexual abuse if taken place, onset of puberty, feelings about it, kind of preparation for the puberty, feelings about menstruation, development of secondary sexual characteristics, adolescent sexual activities like crushes, parties, dating, petting, masturbation, wet dreams, and attitude towards them should be noted. Attitude towards some same and opposite sex, like the patient was timid, shy, or aggressive, need to impress, was seductive, or sexual conquest should be noted. If any kind of anxiety towards the same or opposite sex should also be noted. Sexual practices like sexual problems, homosexual and heterosexual experiences, paraphilias, and promiscuity is important. In adulthood, occupational history, consider the choice of occupation, training, ambitions, conflicts, relations with authority, peers and subordinates, number of jobs and duration of jobs, change in job status, current job and feeling about it is important. Social activity, whether patient has friends or not, is patient withdrawn or socializing well, social, intellectual and physical interest of the patient, relationship with the same sex and opposite sex, depth and duration and the quality of human relationship should be considered in social activity. If the patient is from military background, then general adjustment to the duties, combat, injuries if having any, referral to the psychiatrist, the reason, type of discharge from the services, the veteran status, etc. should be noted. The value systems, whether children are seen as a burden or a joy, whether work is seen as a necessary evil or an avoidable chore or an opportunity, current attitude about the religion, belief in heaven and hell are important to know about the patient's personal history. In adulthood, now coming to the adult sexuality, premarital sexual relationships, age of first coitus, sexual orientation, marital history in terms of common law marriage, legal marriages, description of courtship or role played by each partner, age at the marriage, any case of family planning and contraception, name and ages of the children, attitude towards raising children, problem of any family members, housing difficulties, if important to marriage, sexual adjustments, extramarital affairs, areas of agreement and disagreement, management of money, and role of in-laws in the family should be noted. Sexual symptoms like of sexual psychosexual disorder like anorgasmia, impotence, premature ejaculation, lack of desire should be taken into account. If these are there, should be managed accordingly. Attitudes towards pregnancy and having children, contraceptive practices and feeling about them is to be noted. Sexual practices like paraphilias, coital coital techniques and frequencies should be noted in adult sexuality. Now coming to the pre-morbid personality. Pre-morbid personality is the personality which was present before the onset of illness. The behavior, the traits were present before the onset of illness, to compare with the change in the behavioral pattern during the current episode. So the things which should be look in the pre-morbid personality are prevailing mood, social skills, hobbies, impulsivity, for example in relationship, in decision making, in eating and in sexual behaviors. It is often marked by the follow-up sensation of regret or not, the feeling of guilt was there or not. Planned actions like drifting, criminality and serial killing are not a impulsive behavior, so should not be considered. Coping mechanism in the life, attitude to self like self appraisal, performance, satisfaction with the life, past satisfaction with past achievements, and dealing with the past achievements and failures, and what is the view of future. Moral and religious attitudes and standards present pre-morbidly. Prevailing mood and emotions, reactions to stress, ability to tolerate frustration and disappointments, pattern of coping strategies in the pre-morbid period, personal interest, habits, hobbies and leisure activities, and interpersonal relationships before the onset of illness. And more is the and one more point is the fantasy life. If the patient is having history of substance use and abuse or addictions, should be noted carefully, and the points should be noted in terms of reason for start, perpetuating factors. If there is there any temporal correlation with the current psychiatric illness, routes of use, oral or intravenous. If the route is intravenous in management part, do look for the HIV infection or hepatitis B infection in case the syringes are shared by the peer group. The frequency and amount of the use, history of quit in the past, whether it was supported or unsupported, whether it was done or managed on the basis of OPD or in the IPD, and what about the withdrawal symptoms in the previous period of abstinence. Road traffic accidents if occur any due in the influence of substance, legal issues due to substance use, or any kind of medical problems like hepatic failure or something else in and substance to substance basis. Now come to the closing of interview. The closing of interview, the last 5 to 10 minutes of the interview are very important, and patient often keep important issues or question until the end of the interview, or having at least a brief time to identify the issue is helpful. So if there is there is to be another session that should be apprised to the patient. We will talk more in the next sessions to assess and for the evaluation, and opportunity to ask a question should also be given to the patient if anything has been missed or not looked upon. If the interview was to be a single evaluation session, then a summary of the diagnosis and options for the treatment should generally be shared with the patient. If it is a not a single session, the patient will be seen again, then the professionals may indicate that they can work further on the treatment plan in the next session. So last of the interview, part of the interview is the closing of the interview. It should be closed swiftly. Now, summary of this session is we have learned about the general principles of interviewing, models of interview. We learned about the techniques of interview and the hurdles in the interviewing assessment, the demographic profile in history taking, the chief complaints, history of present illness including the negative history, history of past illness, history of medical illness, family history, personal history, pre-morbid personality, history of substance use, if any, and closing the assessment. Thank you.